Here today at the Epilepsy Association, and it is very fitting that it is Mental Health Awareness Month. So again, the topic today is mental health and epilepsy, what you need to know. Some trouble. Okay. So I'd like to first, again, thank you for the opportunity to talk about this topic. I feel very, very strongly about this topic as it relates to my patients with epilepsy and patients' caregivers with epilepsy. All humans have emotions, regardless of age or ability. How children express emotion, and particularly emotional distress and mental health disorders, vary, related to age, maturity, temperament, and even abilities. In the last few years, I have observed in my personal practice patients and their caregivers to have tremendous added stress. In addition to the challenges of having or caring for someone with a chronic neurological condition, such as epilepsy, they've done so under the unprecedented circumstances of a pandemic, which has really disrupted many of our daily routines, our educational services, our therapeutic services, and even at times our medical services. It's been in the last few years that I became more aware of the mental health needs of my patients. And through this interest, I've been really better able to educate myself, and through that better screen and even treat my patients for mood and behavioral symptoms. It's been through sort of this increased interest and awareness that I've also recognized that this is a long-standing relationship between mental health and epilepsy that well precedes the last few years, but it has been in the last few years that I've seen under the pressure of our current circumstances, more and more problems come to light to me, I guess, as a provider. And so that's when, so it's been eye-opening for me. I really love this Fred Rogers quote for so many reasons. Anything that is human is mentionable, and anything that is mentionable can be more manageable. When we talk about our feelings, they become less overwhelming, less upsetting, and less scary. This really acknowledges the inherent stigma of talking about our feelings and mental illness, and it encourages us and urges us to do it anyway. In fact, talking about it is really the first step to getting help. And if there is one message I can impart during this talk today, it's just to please talk with your doctor or provider about yours or your child's mental health or behavioral concerns. You know, open up, share troubling behavior, share positive experiences, negative experiences, like what's working, what isn't. Because this is really part of epilepsy care, and this is part of living well with epilepsy, and your doctor is a key resource in this regard. Okay, so this is an image from the Disney Pixar movie Inside Out, and I love this movie. Again, it does some very important things. It acknowledges that we all have emotions, a newborn baby, a child, a parent, an adult, a doctor, and that emotions, even hard ones like anger, disgust, fear, sadness, are really sort of foundations of the human experience, and in fact, really do serve very important purposes. And then I think this movie also did a really nice thing of sort of just showing how we experience differences, experience our emotions differently. And again, it's important to recognize that our emotions are sort of integrally related to our experiences and our behaviors. And specifically in children, it's important to recognize this, and to recognize that mental health and behavioral disorders will manifest differently at different ages, and in children and adolescents with different abilities. So now I'm going to sort of review sort of the objectives of what I hope to cover today. And so we're going to review the prevalence of mental health conditions in kids with epilepsy. We're going to discuss the signs, symptoms, and treatments of several common mental health and behavioral disorders in children and children with epilepsy, including the manifestations of those conditions in children who are not verbal or who have associated intellectual disability. This talk will really focus on the most common disorders. It is by no means comprehensive, but we'll be talking primarily about anxiety disorders, depression, and attention deficit hyperactivity disorder, also called ADHD. I'm going to review some variables specific to mental health and epilepsy, with an emphasis on talking about anti-seizure medications and their adverse effects related to mood. We're going to talk about mood symptoms as a symptom of seizures and as part of sort of a broader epilepsy diagnosis. We're going to talk about the psychosocial and psychological variables unique to patients living with a diagnosis of epilepsy. And we're going to talk about suicide. Okay, so the prevalence of behavioral and mental health disorders in kids with epilepsy. Again, epilepsy is one of the most common pediatric neurological disorders in the US. About 500,000 children and youth with epilepsy are living with epilepsy. Kids with experience behavioral, developmental, and mental health comorbidities with a higher prevalence than children and teens without epilepsy. And interestingly, behavioral symptoms are up to 4.8 times higher in kids with epilepsy than the general pediatric population. Depression, anxiety, and behavioral symptoms are reported in about 1/3 of children living with epilepsy when compared to their siblings without epilepsy. And living with a chronic neurological condition, such as epilepsy, with a mental health disorder comorbidity during childhood and adolescence may have lasting impact on one's overall well-being and optimal health-related quality of life into adulthood. And this is why it really is imperative for doctors and patients and their caregivers to address and treat both the epilepsy seizures as well as any comorbid mental health or behavioral disorders. In a study of kids with epilepsy aged 5 to 16 years of age, about 60% met the DSM-5 criteria for a psychiatric diagnosis, but only about 33% received psychiatric treatment. And so I think it's really important to emphasize that this is both under-recognized and under-treated, and may in fact, and these numbers may in fact be an underestimate. I'm having trouble with this. So now we're going to talk about anxiety disorders. So in all children and adults have worries and fears, and anxiety is actually a normal human emotion. It serves a very, very important purpose in that it's sort of an alert, it's a warning, it's part of our neurological system, in fact, that we become aware of, and it makes us pause and look around us and make sure we're safe. It becomes disordered when it interferes with the functioning and quality of life. And it's important to recognize that symptoms of anxiety can look different at different age groups. So in younger children, like toddlers or early childhood, it may manifest differently. They may not have the ability to verbalize, like, I'm feeling worried. They may not have even the cognition of what they're feeling. And so it may manifest as rigidity, some excessive shyness or social anxiety, struggling to adapt to new places and people, and sometimes even sensory sensitivities, like particularly being sensitive to sort of tactile sensations or loud sounds. Older children and teens may present with more of a generalized worry, specific phobias, some obsessive compulsive tendencies, or symptoms of panic disorders. And so in the general pediatric population, anxiety disorders affect about 5 to 18% of patients. I'm having trouble here. So now I'm going to talk a little bit about the specific types of anxiety disorders. We have generalized anxiety disorder, which is, sorry. Oh, sorry. Okay, so sorry, I missed the slide here. So I'm backing up here again. I'm going to talk a little bit about anxiety and epilepsy. So the prevalence of anxiety disorders in kids with epilepsy is estimated between 16 to 50%. So again, quite a bit higher than the general pediatric population. And the risk factors for anxiety disorders and kids with epilepsy is that are specific to epilepsy are associated with a lack of epilepsy knowledge. We do see a higher prevalence in older children, like adolescents and teenagers. Though interestingly, that pattern does improve, as is noted to improve with adults with epilepsy, that over time, sometimes we see more adaptive behaviors related to anxiety in older adults living with epilepsy. Anxiety in epilepsy is associated with an increased frequency of seizures, as well as, again, like the duration of epilepsy. The treatment variables that are unique to anxiety disorders and epilepsy includes, not surprisingly, seizure control, certain anti-seizure medications may have anti-anxiolytic effects. Some of the medications we consider that may have this benefit would be valproic acid, gabapentin, pregabalin, as well as even oxcarbazepine. There can be treatments related to cognitive behavioral therapy with specific education-focused interventions on decision-making and communication skills related to living with epilepsy, as well as self-advocacy. And again, there's also pharmacotherapy. So panic disorder is a sudden and intense feeling of anxiety, fear, and panic, often associated with like a racing heart, a feeling of doom, a feeling of like palpitations, sweating. Again, this can often be unprovoked. And there may be physical feelings, again, like I said, of like physical feelings associated with this. Management involves relaxation strategies, deep breathing, removing yourself from a stressful situation. And this is diagnosed when there are 2 or more panic episodes and with a persistent fear of this happening again. And that's how we diagnose panic disorder. Treatment of anxiety disorders, the first line treatment is cognitive behavioral therapy. And cognitive behavioral therapy, or CBT, is a—
How are you?
I'm fine. How are you?
Again,
Good.
focuses on therapy focus on awareness of thoughts, behaviors, and emotions. Patients are taught to recognize and adapt anxiety-provoking thoughts with the goal of changing patterns of thought, behavior, and avoidance. Again, this may include exposure therapy. Exposure therapy is when there's a recurrent like anxiety trigger or something that induces anxiety.
I had my little egg things. I don't know what to call.
You know, sort of in a very controlled environment, continue to expose that fear or that stimuli to the patient, and then they the thought over time is that there will be less of a physiologic response, less of a panic response. There are also treatment with pharmacotherapy, and the first line treatment for anxiety disorders is a selective serotonin reuptake inhibitor, or SSRI, which we'll talk a little bit more about the uses of SSRIs in epilepsy and the potential interactions with anti-seizure medications on a later slide. We're now going to shift gears and talk about depression. Again, the essential feature of major depressive episode is a period of at least 2 weeks in which there is either low mood or loss of interest, pleasure in most activities. And in children and adolescents, the mood may not be like verbalized or expressed as specifically sadness or hopelessness, but maybe more of an irritability. So again, a child feeling sad and feeling hopeless are not necessarily in of themselves depression. Those are like, again, within the spectrum of a normal human emotion, but again, it's normally in response to an event and it passes. So again, if these feelings are persistent for more than 2 weeks, then it is concerning for a depressive disorder. Again, symptoms in children may not be what we would anticipate in adults. So in adults, it may be more able to verbalize, I feel sad, I feel hopeless, I feel low, no energy. In younger children, it tends to present more with irritability and outbursts, often presenting as anger. We sometimes see a decline in academic performance and sort of a perseveration on like repetitive negative thinking, sometimes feeling guilty, not wanting to maybe do the typically fun things they enjoy. We can see changes in appetite, both with increased appetite or decreased appetite. There can be changes in energy level. Often in adults, we associate this with a lower energy level, but again, in younger kids and children, we sometimes actually see it more of like a revved up type energy, like an irritability and almost like a agitation with almost increased energy. We can have children may present with difficulty focusing or sustaining attention. And again, feeling that those feelings of worthlessness, uselessness, or guilt, which adults also can experience, can be present in children as well. And then again, any sort of feeling of self-harm or self-injurious behaviors or suicidal ideation is certainly concerning for depression. So depression in kids with epilepsy, the prevalence is 23 to 33%. It does affect genders equally. And the variables specific to epilepsy include the unpredictability of seizures, poor seizure control, the lack of independence and autonomy, particularly in middle and childhood and adolescence, perceived and real social stigma. And additional risk factors include family history. Temporal lobe epilepsy has a higher association with depression, and certain anti-seizure medications certainly can contribute or compound symptoms of depression. And specifically, we think of phenobarbital, Keppra, topiramate, perampanel as potentially exacerbating depression symptoms. And I think it's also interesting to note there is a bi-directional relationship. So depression is an independent risk factor for unprovoked seizures and epilepsy, and we don't fully understand why that is. Suicide is a hard topic, but it is one of the leading causes of death for kids, teens, and young adults between the ages of 10 and 24 in the United States. And suicide and suicide attempts are more prevalent in people with epilepsy compared to the general population. The rate of suicidal ideation ranges between 14 to 27% in kids with epilepsy. And in a self-reported screening study, 10% of teens without a known or diagnosed psychiatric comorbidity reported suicidality at the time of routine epilepsy care follow-up. This is alarming, and this is really highlights to me the reason and why we need to be doing this screening as part of our routine epilepsy care. The risk factors for suicide in patients with epilepsy are a diagnosed comorbid psychiatric disorder, and we do find an association with earlier onset of seizures. So when I talk with my patients in my clinic, I always make a point of asking my patients if they need to be, if they'd like to talk with me in private. Sometimes when this comes up in clinic, it's a surprise to the caregivers, as well as maybe even the patient when they acknowledge that they're having these feelings. And once these feelings can be discussed openly, we can kind of come up with a strategy. We can assess how serious it is, what needs to happen. And sometimes if there truly is an intention or a plan of harming oneself, we will refer the patient for emergent psychiatric evaluation in the emergency department. And I always feel, as hard as these conversations are, both for the patient and their caregivers, I always leave these type of appointments with a sense of relief. And I feel that, again, it always emphasizes to me that this is really, really important that we have these conversations, and that patients recognize that their doctor is a resource, and that these are the type of feelings that you can and should share with your provider. So I'm now going to talk about anti-seizure medications and suicidality. The International League Against Epilepsy in 2013 did acknowledge there's a potential link with certain anti-seizure medications and specific psychiatric problems that may include an increased risk for suicidal ideation. But again, it emphasizes that the risk is very low, and that the risk of stopping or refusing to start an anti-seizure medication treatment is significantly greater and carries far greater associated risk of serious harm and even death than not taking an anti-seizure medication. But this really does emphasize to me, while we recognize there is this potential serious behavioral adverse effect with some anti-seizure medications, we need to do that education on the front end. We need to encourage patients and their caregivers to be aware, to monitor their feelings and their emotions when they're starting anti-seizure medications, and to report back if there's any change in mood or if they're recognizing this as a side effect. So for treatment and of depression in children, the first thing is, again, to assess for safety and screen for suicidal ideation. The first line therapy, again, is cognitive behavioral therapy. We also often use dialectical behavioral therapy, family therapy, and group therapy, and pharmacotherapy, including primarily selective serotonin reuptake inhibitors, should be the first drug for the treatment of depression and anxiety in children with epilepsy. They have a favorable side effect profile. There is once daily administration. There is relatively safe drug-drug interactions with most anti-seizure medications, though some of them we do worry about altering levels. We can monitor for that. And it's important to recognize that tricyclic antidepressants are not recommended for use in children with epilepsy, and that there, as well as several other medications that are really contraindicated and may worsen seizures. But selective serotonin reuptake inhibitors are not associated with breakthrough seizures. It's also important to recognize that selective serotonin reuptake inhibitors have not been studied. Most of them have not been studied in children. The ones that we, like fluoxetine, which is Prozac, has, and they've not been studied in children with epilepsy, though the general use has been favorable. This is an area that medicine really could use more research in, is specifically for patients with epilepsy, is more randomized controlled drug studies looking at the effects of these medications specifically with epilepsy. So again, treatment of depression in children, oh, here we are. So, okay, so symptoms of depression and anxiety in children with epilepsy and intellectual disability. Approximately 1/4 of children with epilepsy are functioning at the intellectually disabled or ID range, which is defined as an IQ of less than 70. The presence of intellectual disability in children is associated with increased frequency of mental health and behavioral disorders. However, psychiatric disorders in children with intellectual disability are often under-recognized and undertreated. And I think there's sort of this sometimes assumption that intervention is not needed because anything that's perceived as an abnormal or atypical behavior may be attributed as an inherent part of the intellectual disability. And again, this may lead to disorders being missed or undertreated. However, there are difficulties in diagnosing these disorders in patients who are nonverbal or who have intellectual disability, again, because criteria has not been developed for patients with these with intellectual disability that's been validated in children. So again, it's really important as a parent or a caregiver to recognize changes in your child's patterns of behavior and their moods. And often parents and caregivers really are the best mirror of how their child is feeling. And so they can actually, they may be able to say without fully understanding maybe why, like my child is doing something different. There's something different about how they're experiencing their day or their night or their sleep, or how they're tolerating certain types of stimuli that we really need to be in tune with. Okay, now we're going to talk about attention deficit hyperactivity disorder, which is my personal, one of my personal interests. So, I mean, I think partly because it's so pervasive. 1 in 10 school-age children in the US have a diagnosis of ADHD. And the prevalence of ADHD in kids with epilepsy is higher. It's 30 to 40% in clinic-based studies. And so there is, again, a 2.5 to 5.5 increased prevalence than in children without epilepsy. But I think it's very, very, very important to recognize this is super prevalent in the general population as well. ADHD has a childhood onset before age 12, but can persist into adulthood and may not be diagnosed until adulthood. And the symptoms include persistent inattentiveness, impulsivity, and hyperactivity. And it's diagnosed, again, by a combination of these symptoms, including inattention, which in some kids may look different. In one kid, it may look like just daydreaming. In another kid, it may be more hyper and impulsive and unable to focus. Hyperactivity is actually not required, but it often is seen. And again, these symptoms occur in kind of different proportions for different people and also at different ages. So again, symptoms should start before age 12. And symptoms may interfere with or reduce the quality of functioning. Again, we see this in social settings, the school or academic setting, as well as work or home. And again, behaviors cannot be attributed or related to another mood, developmental, or behavioral disorder, though sometimes they do exist kind of together. you have to screen for those other variables as well when making the diagnosis. And again, the diagnostic screening tools that we use primarily are the Vanderbilt Assessment Scale, the Conners Comprehensive Behavioral Scale, which is something often schools will administer. And sometimes we do more comprehensive neuropsychological evaluation and testing to really understand all the variables at play for these symptoms. Because I think one thing as we're going through this, you may recognize many of these symptoms, inattention, irritability, hyperactivity, impulsivity, they can look like this for ADHD, that can be present in depression, it can be present in anxiety. And so sometimes you really have to try to dig deeper to find what is the actual root problem, or are there more than one issue going on? I will also tell you that, like, when I see a 3-year-old or a 4-year-old or a 5-year-old or a 6-year-old with ADHD, they look very different than a 12-year-old, 15-year-old, 18-year-old. So a younger kid may be more hyper. They may be impulsive. They may do those things like running out, and, running away from you in a grocery store, or running out, and you worry that they'll run into a street without thinking about it. Whereas an older child or teenager, often they may still be a little bit fidgety, but they often are able to sort of control those physical symptoms of hyperactivity. And we tend to see more trouble with organization and executive function, like organizing their homework, organizing their turning in their papers, organizing their thoughts well enough to complete a large task like a research project at school. Again, so it does, these symptoms can look different at different age groups. I apologize, I'm having trouble advancing my slides. So again, so the treatment of ADHD is focused on the first line treatment is pharmacotherapy, and it is stimulant based. There have been ongoing concerns related to sort of a theoretical risk that stimulants may increase risk for seizures. However, the most recent data does not support a statistically significant difference in the rate of seizures before or after treatment with a stimulant class medication. There is also non-stimulant pharmacotherapy. We think of Intuniv, Strattera, and others. And then there is also behavioral therapy, which is actually the first line therapy for a child under 5 years of age. And this again would be parent-child behavioral therapy and strategies, behavioral and social skills training. So now we're going to talk about what contributes to mental health comorbidities in epilepsy. And again, it is complicated and it is multifactorial, and it is not fully understood why in epilepsy we see higher incidences and rates of these disorders. Again, mood disorders and behavioral disorders are pervasive in childhood and adulthood within even the general population. But we do not fully understand why the rates are higher in patients and children and adults with epilepsy. So again, some general risk factors that we have identified. First of all, we do not feel that the research does not support evidence that a child's age, sex, or socioeconomic status is associated with psychiatric comorbidities in epilepsy. We have identified that children with mild to moderate cognitive disorders or intellectual disability have a higher risk of psychiatric comorbidities. Specifically, predictive is a low verbal IQ. There is some increasing recognition that the pathology of epilepsy itself as a potential cause. And so we've found that this is the Connecticut study of epilepsy found that defined complicated epilepsy as a patient with a structural abnormality on their brain, or CT, MRI, and or a full-scale IQ of less than 80. And so in this group of patients, either that have a structurally abnormal brain on MRI or CT, as well as an IQ less than 80, that there is a higher incidence of a comorbid psychiatric disorder. And specifically, there's a higher incidence, again, of ADHD and other conduct disorders. The rates of anxiety and depression are similar between the two groups, between patients with complicated versus uncomplicated epilepsy. So again, another interesting point is that there's a trend over time, and just the risk goes both ways. So again, there is this really interesting inverse relationship between sort of a premorbid diagnosis of anxiety or depression or ADHD and an increased risk for epilepsy. There is also, compared to the new onset of newly diagnosed epilepsy, kids with chronic epilepsy do report higher symptoms of depression, though we do see some, over time, lower rates of anxiety disorders into adulthood. And again, we don't fully understand why, but likely related to adaptive behaviors, acceptance, and education. Some data suggests higher seizure frequency and poor seizure control is related to an increased risk of ADHD. And again, it's super interesting that depression may predate the seizures. So if you have a prior history of depression, there is a 2 to 5-fold increased risk of developing unprovoked seizures. And children with a diagnosis of ADHD, again, are reported to have a 4-fold increased risk for seizures when compared to children without a diagnosis of ADHD. And so I guess the real question is, why is this? And we don't fully know why, but we do know that structurally, the areas of the brain, specifically the frontal and the temporal lobes, have implications in the neurobiology of depression, anxiety, mood, memory, and executive functioning, like organization and planning. And so not surprisingly, these are areas of the brain that are often involved in seizures, activated during a seizure. So I think that there is going to be increasingly understanding of this sort of spectrum of these symptoms as part of the epilepsy itself. So again, anti-seizure medications. In 2008, the FDA issued a warning that anti-seizure medications have that 1.8 time increased risk of suicidality. And anti-seizure medications can have side effects of mood changes. And when I think about the medications that most commonly cause this, I think of levetiracetam or Keppra. Sometimes gabapentin can go either way. Topiramate, perampanel have all known behavioral adverse effects that are reported as part of like the label on the medication. The irritability and aggression are reported in about 10 to 16%, and psychiatric and behavioral side effects are the reason for discontinuing medication in approximately 11% of patients, specifically with higher rates in Keppra and zonisamide and topiramate. So a study of the behavioral symptoms reported by parents 1 month after starting an anti-seizure medication found that about 70% report an increase in baseline psychological symptoms. And so kids have a higher instance of behavioral side effects than adolescents, so younger children. But it can happen at any age, and it can happen with adults as well. No, we do tend to see it in the younger kids more often. Sort of a history of a baseline hyperactivity or impulsivity are sort of predictive of behavioral adverse effects. So again, this is really why you should be reporting these symptoms to your doctor, and we should be screening for this. It doesn't necessarily change what we're going to choose to use to treat a patient with epilepsy. Again, sometimes we have to choose the medication we think is best for the seizure type, but it's important that we do that education, that we be aware, and that we be monitoring for these effects. Polytherapy, or using more than one medication together, may have an increased risk for behavioral adverse effects than a monotherapy regimen. So again, this sort of makes that case that there is some benefit to some screening prior to starting an anti-seizure medication. And that, again, if we can, we should select an anti-seizure medication that is optimal based on both the seizure type as well as sort of what our clinical predictors are for any sort of behavioral side effect. And if we can't, then we should be educating the family to be on the lookout for it and aware of it, and to be reporting any significant mood changes. So in summary, mental health and behavioral health issues are common in children and adults, with an increased prevalence in patients with epilepsy. And the most common comorbid disorders, specifically in childhood, are anxiety, depression, and ADHD. The cause of mood and behavioral disorders in epilepsy is complex and multifactorial, and we do not fully understand it. I think the most important thing I'd like to emphasize is that mood and behavioral disorders are treatable for patients with and without epilepsy. And your doctor should be discussing and potentially screening for behavioral side effects, mood and behavioral disorders as part of your routine epilepsy care at your follow-up visits. And I would really urge you to please share any symptoms of depression, anxiety, ADHD, or any really concerning trends with your doctor. And your doctor will be able to assess or refer you to the proper person to next best assess these symptoms in regards to a diagnosis and treatment.